Bismillah ar-Rahman ar-Rahim. Today's the lecture under concept of degenerative diseases. Objectives of this lecture: to describe pathophysiology, causes, diagnosis, and treatment of following: Parkinson disease, motor neuron disease, Friedreich ataxia, Huntington's disease. Many diseases cause degeneration in different parts of the nervous system without identifiable external cause. Degeneration means regression from more specialized to less specialized type of tissue. It is decline in quality or function. Neurodegenerative disorders involve death of functionally related neurons. Currently, neurodegenerative disorders are classified according by the primary anatomic system involved and the biochemistry of the protein that accumulate in those cells. Degeneration of the cerebral cortex causes dementia, like Alzheimer. Degeneration of the basal ganglia results in movement disorder, like Parkinson or Huntington's disease. Cerebellar degeneration manifested as ataxia. Its example is Friedreich ataxia. And motor neuron disease is the degeneration of the motor neurons of the motor system. First, Parkinson's disease. Parkinsonism, a syndrome consisting of a variable combination of tremor, rigidity, bradykinesia, and a characteristic disturbance of gait and posture. More than 80% of Parkinsonism is Parkinson's disease. The pathology and pathogenesis. The dopaminergic neurons primarily affected in Parkinson's disease are those projecting from the substantia nigra of the midbrain to the striatum of the basal ganglia, which is the caudate nucleus and putamen. Both dopamine and acetylcholine are present in the corpus striatum, where they act as neurotransmitters. In Parkinson's disease, it is generally believed that the normal balance between these two antagonistic neurotransmitters is disturbed because of dopamine depletion in the striatum of the dopaminergic nigrostriatal system. Parkinson's disease occurs in all ethnic groups with a prevalence of 1 to 2 per 1,000 of the general population, 2 per 100 among people older than 65 years. The symptoms of Parkinson's disease appear when about 60 to 80% of nigrostriate dopaminergic neurons have been lost. Early onset Parkinson's disease is onset before 41 years. Juvenile Parkinson's disease when the onset before 21 years. Parkinson's disease has approximately equal sex distribution and starting at an earlier age is generally of slower progression. Clinical diagnosis of Parkinson's disease. The diagnosis is made clinically. The motor features of Parkinsonism, bradykinesia, rested tremor, rigidity, loss of postural reflexes, flexed posture, motor blocks or freezing. The onset is usually unilateral and persistent asymmetry affective side of onset. Signs and symptoms is a progressive and clinical course of years with excellent early response to levodopa. Parkinson's disease can be divided into two types: a kinetic rigid dominant or tremor dominant. In 75% of patients with Parkinson's disease, the resting tremor is the first motor manifestation. The most disabling feature of this disorder is bradykinesia, which is the hallmark of basal ganglia disorders. It encompasses difficulties with the planning, initiating, and executing movements, and with the performing sequential and simultaneous tasks. Bradykinesia, which is defined as a slowness of initiation with progressive reduction in speed and amplitude of a repetitive action. The clinical recognition of bradykinesia requires the identification of small amplitude movements, such as slow and small handwriting, micrographia, speech, monotonic and hypophonic dysarthria, swallowing, dysphagia for liquids, expressionless, unblinking, masked faces, which is called hypomnemia. The shoulder pain, often misdiagnosed as orthopedic or arthritic, and difficulty turning over in bed at night are common presenting symptoms of Parkinson's disease. Mersenne sign, the glabellar reflex of repetitive tapping over the bridge of the nose, produces a sustained blink response, which is called Mersenne sign. The response is not sustained in normal subject. The power and reflexes examination are normal. Sensation is normal. In advanced Parkinson, stooped posture and difficulty in beginning to walk, unsteadiness in turning and difficulty in stopping. The gait itself is shuffling, characterized by small strides, often taken at an increasing rate until the patient is almost running, which means fascination, and by loss of the arm swinging that normally accompanies locomotion. Patients will appear to move stiffly and lack fluidity when standing from a seated position or when sitting, which can often be the first sign when bringing a patient from the waiting room. Turns while walking are especially challenging, and Parkinsonian patients very often requires 5 steps or more to turn. Absence of rest tremor and early occurrence of gait difficulty, postural instability, motor block, these suggest diagnosis other than Parkinson's disease. Non-motor features, these may be present long before the onset of motor features. The period when these features arise can be referred to as the premotor phase of the disease. They are a major cause of morbidity. They are listed as pain, aching pain, and discomfort in the extremities can be prominent presenting symptom, sleep disorders and olfactory dysfunction, autonomic dysfunction, and neuropsychiatric symptoms. Absolute exclusion features, which are potential factors of alternative pathology that argues against a diagnosis of Parkinson's disease, include: first, identified cause like drug-induced Parkinsonism or Wilson disease; second, early severe impairment of autonomic function; third, early severe dementia, sustained remissions, poor response to large doses of levodopa, strictly unilateral features after more than 3 years, corticospinal deficit, cerebellar signs, and then peripheral neuropathy. Differential diagnosis of Parkinson's disease: symptomatic, secondary Parkinsonism, like drug-induced Parkinsonism, Wilson disease; neurodegenerative disorder with Parkinsonism features; Parkinson plus syndrome; early falls, postural instability, and lack of response to levodopa are clues; then depression, and finally essential benign familial tremor. Now the treatment. Pharmacological management. The choices of drug depend on age of the patient, stage of the disease, level of functional disability, cognitive status, and side effects of the drugs. The pharmacological management, the neuroprotective treatment. To this date, the only treatments with possible evidence of disease modification are monoamine oxidase type B, which is called MAO type B inhibitors, and coenzyme Q10. Symptomatic pharmacological treatment include levodopa, selective catechol-O-methyltransferase COMT inhibitor, dopamine agonist drugs, and anticholinergic drugs, non-selective muscarinic antagonist. Motor complications of levodopa therapy. It occurs after 3 to 6 years. It is currently believed that motor complications of levodopa therapy are largely due to loss of the capacity for storage and physiological release of the dopamine formed from levodopa in the Parkinsonian striatum. It is a result of disease progression coupled with the short half-life of levodopa. The motor complications of levodopa therapy. First, levodopa-induced dyskinesia, which can be classified as dystonia and chorea. Dystonia first, can be classified as peak dose dystonia, off-period dystonia, and diphasic dyskinesia, while chorea can be classified as peak dose chorea and square wave chorea. Second complication is the motor fluctuations in response to levodopa. A. Wearing off phenomena. B. On-off phenomena. C. Unpredictable offs, which is called sudden offs. D. Dose failure. E. Beginning of dose worsening and end of dose rebound. And F. Motor blocks. Treatment of motor complications. This can sometimes be solved with change in the drug regime, particularly the addition of dopamine agonist and Stalevo and or controlled release formulations. Second, amantadine, which reduce the drug-induced dyskinesia, and MAO-B inhibitors used as an adjunct to levodopa in patients with motor fluctuations. As Parkinson's disease progresses, the development of disabling motor fluctuations that are not controllable using oral medication. So at this point in the disease, advanced therapies are considered, which include infusional therapies such as subcutaneous apomorphine or intraduodenal levodopa gel infusions. Treatment of behavioral or psychiatric disorder. First, sleep disorders can be treated by sleep fragmentation. Patients with a frequent nighttime awakening due to nocturnal akinesia can be treated with supplemental doses of carbidopa levodopa at night. Daytime sleepiness can be treated by caffeine. Excessive daytime sleepiness can be managed with modafinil. Dementia and depression. The cholinesterase inhibitors may improve symptoms of dementia, and antidepressants and dopamine agonists may improve depression. Psychosis. Threatening psychotic symptoms require a sequential reduction or discontinuation in medication according to their decreasing hallucinogenic potential. Anticholinergic medications, amantadine, dopamine agonists, dopamine oxidase inhibitors, and lastly, levodopa, and if no improvement, treated by clozapine. Constipation may respond to dietary adjustment, but patients often require laxatives. Postural hypotension may respond to high salt diet, but may also require increasing the blood volume by fludrocortisone or increasing the peripheral vascular resistance by midodrine, or if midodrine is ineffective, indomethacin or pyridostigmine. Surgical treatment. The major techniques include lesions or stimulation within regions of the thalamus and the globus pallidus, ablative surgery like pallidotomy and thalamotomy. The use of this ablation has decreased greatly since the introduction of deep brain stimulation. Deep brain stimulation for thalamus, internal globus pallidus, and subthalamic nucleus. And lastly, grafting of fetal mesencephalic midbrain cells into the striatum. Now, motor neuron disease. It is possibly the most devastating of the neurodegenerative disorders. It is persistently progressive motor neuron disorder leading to death from respiratory paralysis. The median survival is from 3 to 5 years. Epidemiology. In most societies, there is an incidence of 1 to 3 per 100,000 and a prevalence of 3 to 5 per 100,000. Males are somewhat more frequently affected than females. It usually developed after the age of 50 but can present much earlier. Very uncommon before the age of 30 years. Younger presentation is more often seen in familial motor neuron disease, which accounts for about 5 to 10% of cases. The pathology of motor neuron degenerative disorders involves the lower motor neurons in the spinal cord and the cranial nerve nuclei, and upper motor neurons in the motor cortex. Although at its onset, motor neuron disease may involve selective loss of function of only upper or lower motor neuron, but it ultimately causes progressive loss of both categories of motor neurons. The affected motor neurons undergo shrinkage, often with accumulation of the pigmented lipid, which is called lipofuscin, that normally develops in these cells with advancing age. The death of the peripheral motor neurons in the brainstem and the spinal cord leads to denervation and consequent atrophy of corresponding muscle fibers. As denervation progresses, muscle atrophy is readily recognized in clinical examination. This is the basis for the term amyotrophy in the name for the disease. The loss of cortical motor neurons result in thinning of corticospinal tracts that travels via the internal capsule and the brainstem to the lateral and anterior white matter columns of the spinal cord. The loss of fibers in the lateral columns and resulting fibrillary gliosis impart a particular firmness which is called lateral sclerosis. So the term which is called amyotrophic lateral sclerosis. Patterns of involvement in motor neuron disease include bulbar palsy, spinal muscular atrophy, pseudobulbar palsy, primary lateral sclerosis, and the most common type is amyotrophic lateral sclerosis. The clinical manifestations, typically with the lower motor neuron dysfunction and early denervation, the initial sign of the disease is insidiously developing asymmetric weakness, usually first evident distally in one of the limbs. Weakness caused by denervation is associated with the progressive wasting and atrophy of muscles, and particularly early in the illness, spontaneous fasciculation. When the onset is difficulty with chewing, when the initial denervation involves bulbar rather than limb muscles, the problem at onset is difficulty with chewing, swallowing, and movements of the face and tongue. Early involvement of the muscle of respiration may lead to death before the disease is far advanced elsewhere. With a prominent corticospinal involvement, there is hyperactivity of the muscle stretch reflexes, tendon jerks, and often spastic resistance to passive movement of the affected limbs. Virtually any muscle group may be the first to show sign of disease, but as time passes, more and more muscles become involved until ultimately the disorder takes on asymmetric distribution in all regions. It is characteristic of amyotrophic lateral sclerosis that regardless of whether the initial disease involves upper or lower motor neurons, both will eventually be implicated. So the diagnosis of motor neuron disease need absence of the following: pain or sensory changes, bowel and bladder dysfunction, mental changes, cerebellar signs, and ocular muscle involvement. All favor motor neuron disease. Investigations: there is no definitive diagnostic test. Electrophysiologic examination typically reveals evidence of fasciculations and denervation, which are fibrillation potentials and positive sharp waves, and reinnervation manifested as large polyphasic units in affected and clinically unaffected limbs with normal cessation. The current role of neuroimaging is to rule out other pathological processes that could otherwise account for the clinical symptoms. Differential diagnosis: because motor neuron disease is currently untreatable, it is imperative that potentially remediable causes of motor neuron dysfunction has to be excluded. This is particularly true in cases that are atypical by virtue of restriction to either upper or lower motor neuron, involvement of neurons other than motor neurons, atypical findings on electrophysiological testing. The compression of the cervical spinal cord or cervicomedullary junction from tumors in the cervical region at the foramen magnum or from cervical spondylosis with osteophytes projecting into the vertebral canal can produce weakness, wasting, and fasciculation in the upper limbs and spasticity in the legs, closely resembling motor neuron disease. Other treatable disorders that occasionally mimic motor neuron disease are chronic lead poisoning and thyrotoxicosis. These disorders may be suggested by the patient's social or occupational history by unusual clinical features. Benign fasciculations are occasionally a source of concern because on inspection they resemble the fascicular twitching that accompany motor neuron degeneration. Treatment: there is no treatment capable of arresting the underlying pathological process in motor neuron disease, but edaravone, which is called Radicava, is a free radical scavenger, is a new FDA-approved treatment which may slow clinical progression in early-stage disease. While drug raliuzole was approved for the use in motor neuron disease because it produces a modest lengthening of the survival, it may reduce excitotoxicity by diminishing glutamate release. In the absence of a primary therapy or for the motor neuron disease, a variety of rehabilitative aids may substantially assist motor neurons disease patients. Foot drop splint facilitate ambulation by avoiding tripping on floppy foot and obviating excessive hip flexion. Finger extension splint can't potentially grip. Anticholinergic drugs, if drooling of saliva is troublesome. Disabling emotional lability can be treated with antidepressant. A semi-liquid diet or feeding via nasogastric tube may be required for severe dysphagia, and respiratory support may be life-sustaining. Now we deal with an example of cerebellar degeneration, which is Friedreich ataxia. It is account for approximately 1/2 of all cases of hereditary ataxia. It is an autosomal recessive spinocerebellar disorder which has a slow but relentlessly degenerative course. The pathophysiology: the current hypothesis is that frataxin is a mitochondrial protein important for normal production of cellular energy. A defect in its action may result in abnormal accumulation of iron in mitochondria, leading to excess production of free radicals, which then results in cellular damage and death. The neural pathways affecting Friedreich ataxia are those associated with large neuronal cell bodies and extensive axon elongations, which are the long tracts of the dorsal column, pyramidal system, peripheral nerves, and dentate nuclei of the cerebellum, with secondary involvement of dorsal nucleus of Clark. Frequency of Friedreich ataxia: the prevalence of Friedreich is 1 to 2 per 100,000 of the international population. Men and women are affected equally. Women have a significantly better prognosis than men. The clinical manifestations: the symptoms usually begin when an individual is aged 8 to 15 years. Ataxia of gait is the most frequent presenting symptom. The hands usually become clumsy months or years after the gait disorder, and the dysarthritic speech appears after the arms are involved. In some patients with Friedreich, pes cavus and kyphoscoliosis precede the neurological symptoms, and in others these follow by several years. The deep tender reflexes are absent. Plantar responses are extensor, means Babinski present. Distal wasting, impaired vibration and proprioception sense. The diabetes mellitus occurs in 20% of patients with Friedreich. The heart disease is present in 90% of patients with Friedreich, and significant sensory neural deafness occurs in 10% of persons with Friedreich ataxia. The diagnosis is essentially a clinical one, and the confirmation of diagnosis by DNA testing is recommended for all patients in whom Friedreich is clinically suspected. MRI are normal or show mild cerebellar atrophy, usually observed late in the disease, so the cervical spinal cord often is atrophied, so it is first to be sent. Echocardiogram exhibits evidence of hypertrophic cardiomyopathy in approximately 40% of patients, and ECG is abnormal in approximately 2/3 of patients. No definitive therapy to delay, stop, or reverse the progression of Friedreich ataxia is known till now. A number of therapeutic strategies based around improving mitochondrial function are being developed. Diabetes must be managed. Cardiac failure and arrhythmias should be treated as they arise, and surgical care for foot deformity and scoliosis may be of benefit in selected patients. Mortality and morbidity: more than 95% of individuals with Friedreich cannot ambulate by the time when they are aged 45 years, and on average patients lose the ability to walk 15 years following onset of symptoms. The mean age of loss of ambulation is 25 years. Age at death is rather variable. Death usually occurs in mid-4th decade of life and tend to be earlier if the heart disease and diabetes are associated. Finally, we talk about Huntington's disease. It is a hereditary disorder of the nervous system characterized by gradual onset and subsequent progression of chorea and dementia. It occurs throughout the world. Symptoms usually do not appear until adulthood, typically between 30 and 50 years of age, by which time these patients have often started families of their own. Thus, the disease continues. Huntington's disease is a autosomal dominant disorder due to a mutation in the Huntington gene on a chromosome form. The disease shows complete penetrance so that offspring of an affected individual have a 50% chance of developing it. It is associated with cell loss, particularly in the cerebral cortex and striatum, which involve the caudate nucleus and putamen. The biochemical studies have shown that concentration of the inhibitory transmitter GABA, its biosynthetic enzyme glutamic acid decarboxylase, and acetylcholine, and its biosynthetic enzyme choline acetyl transferase are all reduced in the basal ganglia of the patient with Huntington disease, and the concentration of dopamine is normal, in contrast due to Parkinson when the dopamine is depleted. The symptoms usually begin in the 4th or 5th decade, and the disease is progressive with an average lifespan after onset of about 15 years. The initial symptoms: first, dementia. The earliest mental changes often consist of irritability, moodiness, and antisocial behavior. Chorea. Second, chorea. Movement disturbance may be characterized initially by no more than an apparent agitation or restlessness, but grossly abnormal choreiform movements are eventually seen. Third, Westphal variant, especially in cases developing during childhood, but occasionally in adult onset cases as well. The clinical picture is dominated by progressive rigidity and akinesia with little or no chorea. The diagnosis suggested by accompanying dementia and a positive family history. 4. Epilepsy and cerebellar ataxia are frequent features of the juvenile form but not of adult cases. Regarding family history, in cases in which a positive family history cannot be obtained, it must be remembered that the early death of parent may make the history incomplete, and the relatives often conceal the familial nature of the disorder. Regarding investigation, the genetic testing now provides an accurate and definitive means of establishing the diagnosis and also permits the presymptomatic detection of the disease, while imaging, CT or MRI often demonstrate atrophy of the cerebral cortex and caudate nucleus in established cases. Reduction in striatal metabolic rate may be demonstrated by PET scan. Treatment: there is no cure for Huntington disease, which as a rule terminates fatally 10 to 20 years after clinical onset. There is no treatment for dementia, but the movement disorder may respond to drugs that interfere with the dopaminergic inhibition of striatal output neurons. These include drugs that deplete dopamine from nerve terminals, such as reserpine or tetrabenazine, and dopamine D2 receptor blocking drugs such as haloperidol, or atypical antipsychotic agents such as olanzapine. Selective serotonin reuptake inhibitors may help to reduce aggressiveness and agitation. A role of deep brain stimulation is uncertain, but it has been used successfully in a small number of patients to treat chorea. Thank you.